Hello and welcome to this mini-gem, brought to you by AMY, the Association for Elderly Medicine Education. I'm Selina Sangha and I'll be talking to you about how in elderly medicine things are not always as they seem. Our learning outcomes for this presentation are to understand typical and atypical presentations of illness, to understand why atypical presentations are more common in the elderly, and also to understand the importance of making a medical problem list and the importance of comprehensive geriatric assessment. Firstly, let's think about a typical presentation of a 62-year-old man with a past medical history of angina. He presents with central chest pain that spreads to his left arm and shoulder. It lasts 1 hour at rest and he describes the pain as crushing. He rings the GP, who immediately organises an urgent ambulance, and he arrives in A&E within half an hour. The ECG shows an acute anterior myocardial infarction. The diagnosis is easy, and the fascination for the cardiologist is getting him to the catheter lab and for immediate intervention, which can be life-saving. Compare this to an 86-year-old man who has a background of type 2 diabetes and chronic obstructive airways disease. One day he feels unwell, is more short of breath than usual and has some epigastric discomfort. A neighbour calls in, thinks he looks unwell and not his normal self, and she calls out the GP. She gets put through to an out-of-hours service and a nurse phones back after an hour. She goes through a symptom list. He does not sound very urgent and gets triaged to a 6-hour visit from an out-of-hours doctor. He was eventually seen, by which time it was fairly late at night. The doctor is not sure what is wrong with him, but thinks he looks unwell and is unhappy to leave him alone at home. He gets admitted to A&E. He is eventually seen and has an ECG, which shows an acute anterior myocardial infarction. By this time, it is longer than 8 hours after his initial presentation. Patient 1, the 62-year-old man, is a typical presentation of a myocardial infarction. Patient 2 is an atypical presentation in a frail elderly person. He has epigastric pain and no chest pain. He presents with being breathless but also has a background of COPD as well as diabetes. It is a neighbour who is worried about him and who contacts the doctor, and there is a big delay in diagnosis. He does not receive optimal treatment. So why do we get atypical presentations in older people, and why is it a problem? There are 4 reasons. First of all, there are age-related physiological changes, and older people have a blunter response to illness. They do not have the same acute physiological response that young people have. Secondly, there is a loss of physiological and functional reserve in frail older people, and illness may present as a so-called geriatric giant: falls, incontinence, confusion and immobility. Thirdly, old people are much more likely to have other co-morbidities which interact and affect the presentation picture. And finally, older people often underreport symptoms and more often have to rely on the caregiver for the history. There are many examples of atypical presentations which in fact can be more typical in older people. Pulmonary embolus can present as a syncope or a fall rather than with pleuritic chest pain, hemoptysis or breathlessness. Sepsis may be more subtle and present as an alteration in mental state with confusion or falls, and there may be no fever or rise in white cell count. Pneumonia in old people may present as difficulties doing activities of daily living, delirium or falls. Classic signs such as cough, fever and pleuritic chest pain may be absent. However, increased respiratory rate is common. An acute abdomen in an older person is less likely to have classic signs such as severe pain, tenderness and guarding. Comorbidities may affect presentation. Multiple comorbidities may be synergistic and contribute to a single presentation. For example, a patient with reduced mobility due to osteoarthritis and heart failure being treated with diuretics can present with incontinence. This means that sometimes these symptoms respond to multiple interventions or perhaps even just one. Reducing the diuretics and changing the treatment for heart failure may help prevent the incontinence and tip the balance in the patient's favour. Sometimes one comorbidity can lead to a presentation in another system, the so-called causal effect. For example, a patient with sepsis due to pneumonia may develop atrial fibrillation, which leads to a presentation of heart failure. Just treating the atrial fibrillation may not improve the patient's breathlessness, as there is an underlying pneumonia. A previously hidden comorbidity can be unmasked after the occurrence of an external stressful event. For example, an elderly man presenting with worsening of heart failure following his wife's death. The heart failure may be due to not taking his medication, and in turn, this may be due to hidden cognitive impairment, which has only become apparent after his wife's death. What are the implications of these atypical presentations? Because of the importance of underlying comorbidities, it is important to do a list of comorbidities and remember that the main presentation may be synergistic or causal, or the real diagnosis may be hidden. Plus, elderly people often present with functional problems with social connotations, as well as purely medical problems. Then, comprehensive geriatric assessment is crucial, which should be multidisciplinary. The main learning points from this presentation are that illness often presents atypically in the elderly, and this is because of age-related physiological changes, loss of physiological reserve, the presence of comorbidities, and underreporting of symptoms. Because elderly people can present atypically, this requires a different approach, which includes compiling a problem list and also a comprehensive geriatric assessment. Thank you for listening to this mini-gem.